This podcast is for informational purposes only and does not provide medical advice. Always consult your physician or other qualified health provider with any medical questions and never delay care because of something you hear on this podcast. Welcome to Prostate Cancer Real Talk. Did you know that 1 out of 8 U.S. men will be affected by prostate cancer? And Black men are 50% more likely to be diagnosed and twice as likely to die from it. Meet Elle and Shay, a married couple impacted by prostate cancer who have faced it, fought it, and defeated it. Join in now where we answer questions, share personal stories, and fellowship in our safe, judgment-free space. Expert guests include urologists, surgeons, researchers, counselors, nutritionists, patients with their families, and more. If you or someone you know has been impacted by prostate cancer, you've found a welcoming place for information and support. In this episode, we welcome 2 distinguished doctors from Cedar Rapids, Iowa's Mercy Urology Center. Dr. Matthew C. Ferroni is a leading urologist specializing in minimally invasive and robotic surgery for prostate and other urologic cancers, while Dr. Michael Marquardt is a radiation oncologist treating prostate, lung, and other cancers. Both are central to the Mercy Urology Center's Multidisciplinary Prostate Cancer Clinic, which guides patients through advanced treatments while emphasizing early detection. Localized prostate cancer surgery in the form of radical prostatectomy and radiation therapy offers similar cure rates but differ in side effects and patient suitability. Elle and Shay will explore both treatment options with our guests. Our topic: making the decision, surgery versus radiation. Elle and Shay, take it away.
Thank you very much for that great introduction, Dennis, and welcome Dr. Ferroni and Dr. Marquardt. We're very happy to see you today, and we were with you a few weeks ago in Iowa, Cedar Rapids, Iowa, at the Prostate Cancer Awareness event. Shay and I had a wonderful time.
Yes, we did. Hi, Dr. Matt. Hi, Dr. Michael. How are you guys?
Hey.
Good to see you again.
Yeah, thank you.
Thanks for having us in Cedar Rapids. We had a great time there.
Yeah, we did too.
Dr. Matt, we're going to start with you because we recently recorded some episodes and we had guests. You're the urologist on the team, correct?
Correct.
Okay, so we had a guest that had a PSA level of 600. Have you ever heard of that before? Elle and I was floored. We've never, ever heard of a 600 PSA. We never even knew it was possible. So can you tell us how potentially this guy ended up with a 600 PSA?
Yeah, no, we see that unfortunately a lot too often. And that's a process that doesn't happen overnight. So a PSA level, usually above about 50, generally is almost certainly associated with metastatic prostate cancer. There can be PSAs lower than that, and we can find evidence that the cancer is outside the prostate. But generally, above those levels, we're almost convinced that that guy has had prostate cancer spread outside. The reason that happens is guys don't get screened, and that's the bottom line. We fight this battle a lot in the Midwest, where men have this sense of, if I feel okay, if I'm not having any symptoms, I don't need to see a doctor. Doctors are for solving problems. Doctors are for fixing disease. And they don't wrap their heads around the concept that screening is meant to find cancer before it causes any symptoms. So these are the guys that either start developing pain in their back or they fall and have a fracture from a minor fall that you would say, well, why would somebody have a fracture from just tripping on a sidewalk? And it turns out they get a scan and they have prostate cancer spread all over their bones. And then they get a PSA and it's quite elevated. So a 600 is high. It's not certainly the highest I've seen. I've seen the PSA in the thousands. And those are men that, again, generally when we get imaging, have a multitude of spots that have spread.
Oh, wow. So, I mean, his story was that he was going to the doctor, but they never asked him or never, gave him a PSA screening. And he didn't find out that he had prostate cancer. Like you said, it was metastatic at that point until he was 70.
Yeah. What's really unfortunate, Shay, is that when men go to the doctor, they trust that their doctors are doing everything to protect them. And the reality is that there are some really misnomer information out there about prostate cancer. And their guidelines for screening for prostate cancer have changed significantly over the last 10 years. Some primary care providers are still stuck in the past. They're still stuck in 10 years ago, actually like 12 years ago now, when the United States Preventive Services Task Force came out with recommendations against prostate cancer screening. And that was based on very, very poorly conducted trials at the time, showing that prostate cancer screening didn't have any real benefit. Those guidelines have been reversed because we know that was garbage. We know that prostate cancer screening saves lives and saves men from metastatic disease. But unfortunately, a lot of PCPs don't keep up with their own basic guidelines. And men don't pay attention when they get labs done and they're checking their cholesterol and their kidney function and all the other things that happen before a wellness exam. They're just assuming maybe that's being checked. And when they're told that all your labs are normal, they may assume that they're being screened for cancers that they're not being screened for. So one of our main missions is to empower men to know if they're being screened. And then nowadays, when you have my charts and things on your phone detailing all your records, it's not that hard to create a login and review your records. And if you're not being screened, maybe there's an appropriate reason for that, but at least have that conversation with your doctor and ask the question.
We're going to bring in Dr. Marquardt here.
Dr. Michael.
Dr.
there you go.
Michael.
Yeah.
Thank you, Shay. Thank you.
We're friends now, so
totally.
we can say Dr. Matt, Dr. Michael.
Absolutely.
Dr. Michael is an oncology radiologist. And so the question for you is to start with, at what point in the prostate cancer journey do you come into play? At what stage would a patient come to see you?
Well, so we have a little bit different process here at Mercy. We have this multidisciplinary prostate cancer clinic. And so most guys that have a new diagnosis of prostate cancer, they'll be coming through that clinic. So that includes a meeting with Dr. Ferroni and myself. And so I actually meet people pretty early in the prostate cancer journey. Certainly there are those guys that we don't recommend any treatment for, and I think that's totally reasonable to still meet with them. A lot of those guys are younger, and they may need treatment in the future. And so it's always nice to kind of hear what might be coming in the future, even if I don't need treatment now. And so even those guys that we don't necessarily recommend treatment for right away, we'll still be meeting with them. And I think that's helpful to get all the information out on the table. But from every other person who has been diagnosed with prostate cancer, it's pretty reasonable to meet not only with the surgeon, but also the other cancer team, including the radiation oncologist.
Hey, listeners, metastatic prostate cancer means that the cancer has spread from the prostate to other parts of your body. If you or a loved one has been diagnosed with metastatic prostate cancer, consider a Pfizer clinical trial as your next step. To check your eligibility, go to www.mevpro-studies.com. That's MEVPRO-studies.com. So I'm going to be the referee here, and I'm going to throw up a jump ball. Whoever wants to take it can take it. So one of the things we want to do today with the two of you gentlemen, doctors, is to kind of talk to guys and advise them. The big question is the decision, surgery versus radiation. Okay. And I'm a guy listening to the show. I've been diagnosed. How do I decide which road I'm going to go down?
I think that, Elle, what I really loved about what you just said is, as the patient, how do I decide, right? It's your choice. It's the patient's choice. Now, yes, there are often factors that may make one better than the other. There are occasionally factors that make one not possible or really much more dangerous than the other. But most men, it's an option to have either surgery or radiation. Now, in general, we tell guys, statistics show, and our experience is really men in their 50s tend to have surgery because they're younger, they're more, they have less risk factors, less medical comorbidities, they have more chance of getting through surgery with less complications and less impact of quality of life. Guys in their 70s, most of them have radiation because most of those guys tend to have other medical problems that make surgery maybe not their best option, especially going under anesthesia, having a long surgery, the recovery process. There are certainly data supporting older men over 65, 70 have harder times with getting their continence back, at least earlier than younger guys. But guys in their 60s is usually that wheelhouse where it is 50-50, and it is an individual choice. And Michael said earlier, we try to balance the effectiveness and the risk profile or the side effects of treatment and have guys make their own empowered decision, which is really important.
Dr. Michael?
Yeah, so I'll echo what Dr. Matt there said. It's really kind of a continuum. So the younger you are, generally, we're talking more about surgery. The older you are, generally, we're talking more about radiation. And yeah, it really comes down to the ability to heal up from a surgery. And the second thing is the likelihood that you would need any additional treatment down the road. And so a lot of times what we'll be talking about with guys in their 50s that have a diagnosis of prostate cancer is like, look, we have multiple different treatment options for you available. What we want to do is not burn any bridges when we first start the treatment process, kind of going down that pathway. And so in that case, surgery generally burns the fewest bridges, so to speak. And you still have all the other treatment options available. And so what we want to do is just maximize that chance for cure, especially in those guys that are younger, who there's a higher chance that they may have the cancer come back. Mm-hmm. As you get older and older, prostate cancer is generally a slower growing sort of cancer. If you're in your 70s, the likelihood of the cancer coming back and then you actually needing some sort of additional aggressive treatment decreases just based on your longevity. And so that's the other component to that discussion of surgery versus radiation in terms of age, is not only your ability to heal up from a surgery, but also what's the likelihood of you needing some other treatment approach.
Okay. So I'm going to take myself as a case study, for example. My Gleason score was 7. It was a 4+3. And I recall having the conversation with my surgeon, and we were weighing my options, or our options, always include Shay. So I primarily decided on surgery, all right? So the question is, for that decision, how do you decide whether you're going to do surgery or radiation? What are some of the side effects of both? All right. And the real decision maker for me was when my surgeon told me that once you have, and you can validate this or challenge it or whatever, my surgeon said that once you have radiation, the likelihood or the possibility of surgery down the road is at least more difficult to impossible. What is your perspective on that?
Yeah, that's the number one reason I think LY guys gravitate towards surgery, or at least come into it thinking they want to do surgery, because they hear that and they say, well, we're going to keep a window open. If the surgery, doesn't get all the cancer, or if I have a recurrence later, I can always have the radiation after surgery. You start with the radiation. Yeah, we don't really do surgeries often after radiation. We only do that in maybe younger guys who chose the path of radiation first and then had a recurrence, and it just makes things a lot more challenging and complicated. I think, a lot of the decision boils down to the difference of surgery being all at once. It's a one-time event. You have a surgery, but there's a significant healing process over the course of 6 weeks up to 3 months in terms of getting your continence back, having to wear Depends. All guys after surgery are going to have leakage of urine. That's kind of a negotiable, but all guys get their control back at different times. And of course, we support men through that process, with pelvic floor physical therapy exercises, all the things they need to do to get that continence back. And in 95% of guys, long term, they do get that continence back. But that short term incontinence can be very embarrassing, can be very frustrating. And a lot of guys hear that and they don't want to go through that because it is a healing process. Surgery also very much initially or very quickly affects sexual function. The nerves that give guys erections run right alongside the prostate. And depending on the surgery, depending on a guy's risk, his Gleason score, how high risk he is, sure, we can perform what we call a nerve sparing operation, where we push those nerves away while we're in there taking the prostate out, which can long-term make erections come back, but it's not perfect. And in fact, it's often more disappointing than we're hoping it's going to be. So prioritizing urination, incontinence, and erections in the context of it all happens to you right away and then things get better, whereas radiation generally is a much slower process in terms of the immediate impact. And I'll defer to Michael to talk about those things, but in general, it's not this big hit recovery. It's more of just like a putter along the way while things change a little bit to your body and then typically get back to where they were before.
Mm-hmm. And before Dr. Michael jumps in, there's another criteria that I considered that was meaningful to me, and that was the frequency of the radiation treatments, the travel, the every whatever. I'll let you talk about the frequency, Dr. Michael, but that was another factor. It was the frequency of the treatment, and I call it a one-way street, okay, that I didn't want to go down. Your thoughts?
Yeah, so radiation treatments are delivered, through multiple different modalities. But standardly, though, we're talking about every day, Monday through Friday treatments for a series of weeks. And so, unlike surgery, where it's like you say, it's a one and done in terms of the actual procedure. Even though you're undergoing general anesthesia, and there's that consideration. Radiation, you have to come back and forth every day, Monday through Friday, for multiple weeks. Now, certainly there are those.
You said multiple weeks. I mean,
multiple weeks.
How many? Yep. How many are we talking?
Yeah. And so typically it's anywhere from 4 weeks to 8 weeks. There are certainly guys that have some cancers that we can treat just over the course of a week, so just 5 days. But most guys are going to be getting treatments anywhere from 4 to 8 weeks of treatment. And so that's every day, Monday through Friday. Each treatment takes about 10 minutes. You're probably door to door, 20 to 30 minutes or so. And so you have to be able to schedule that every day, Monday through Friday, like a little mini job, for a month or 2 months typically. And that can be pretty challenging for guys that are either working or coming from quite the distance away. And so that's certainly one consideration we have, especially in a state like Iowa, where we're getting guys from many different counties all coming to one area. Some guys are traveling from an hour or more away each way, and so that can be challenging by itself. It's unfortunate, but radiation machines are very expensive. There's a lot of regulation that goes into it, so we can't put these machines everywhere, and so. A lot of times, especially in rural areas, we're talking about having long distances of traveling for multiple days, or multiple weeks.
So do those hurdles actually intervene in a person's decision-making? What have you seen with that?
Yeah, absolutely. I think the three big categories, and we kind of touched on each of these a little bit so far, but, one is the process. 2 is the side effect profiles, and 3 is our backup plan. And the process that's one that by itself really affects quite a lot of guys. They have this idea that with the surgery you can get in, get out, and then you're on the golf course, or you're back at work. And with the radiation, it's almost kind of like you have to continue to think about how you have cancer. Over and over again. It's this reminder for, multiple months. And so that, I think by itself, makes guys go one way or the other. And so certainly I talk about that with guys pretty regularly. I say, look, surgery is, you're cutting something out, going under general anesthesia, but it's one and done. Radiation, there's no needles, no pokes, no anesthesia, but you have to come back and forth here for multiple times, at minimum 5 treatments, but most of the time it's, 4 weeks to 8 weeks.
So given the frequency and, for lack of a better term, inconvenience of radiation treatment, why would somebody choose that?
Yeah, there are certainly guys that look more so to the side effect profiles, and that I see regularly when we're having this conversation is the tipping factor. Some guys are, like Dr. Matt was saying, some guys are really, really worried about the incontinence issue with surgery, and incontinence with radiation is pretty minimal. Typically the side effects we see with radiation are you having to pee a lot more often, and then you have a lot more urgency with that as well. And so you run into the bathroom back and forth. And, I think for some guys, they weigh the different side effects and say, I'd rather just go to the bathroom more often than just have leakage of urine. And, like Dr. Matt was saying, the leakage of urine in most guys, it's temporary, but even that little bit of an issue kind of tips guys over the edge. Certainly sexual function as well as a consideration. Typically, we see less of an issue with erectile function with radiation as compared to surgery. There was actually a great study.
That'll make you drive an hour each way.
Oh yeah, totally. Yeah. No, and we've had nice randomized studies where we look at surgery versus radiation versus just active surveillance, and they've reported out in these studies, the differences in the side effect profiles. And it's really kind of nice to see, how when you're looking at those studies, you have, more rates of, urinary frequency and urgency with radiation, but less of an issue with erectile function. The other one that I haven't touched on is, we have more issues with looser bowel movements. We typically don't have any issues with you losing control of your bowels, but it's, issues where you're going more often, and that is another balancing factor. So I'd say that most guys who are kind of in that window where they're seriously debating surgery or radiation and ultimately fall on the radiation side is probably due to the side effect profile more than anything. And other guys will also tell me, I'm retired, I'm not really doing a whole lot else right now anyway, so they don't have as much of a problem with it. But certainly when you guy who's in his 50s is working, it's a real pain in the butt to come back and forth their treatments every day. And so that kind of also helps to kind of push the age a little bit one way versus the other, where the younger guys tend to go to surgery because they can get back to doing whatever life commitments they have at that point in time.
So Dr. Michael, I have a question. So L had surgery. And so when he goes back now, his his levels are very low and there's no detection of cancer. So with radiation, can a person get I think less than zero?
Less than 0.01. They never say all zeros, but if you're less than 0.01, they call that undetectable, which is one of my favorite words now.
Okay. So Dr. Michael, so is that possible with radiation? So the process, they get radiation versus surgery. So does their PSA ends like L's?
Most of the time it doesn't. Most of the time it goes down to a low level, but not undetectable. We're typically seeing things on the range of 0 point something, like 0.5 to maybe 1 point something. But most of the time it doesn't get down to what we call undetectable. Now, there certainly are cases, especially if you get hormone therapy with it, which is a whole nother discussion, where you can see it go down to undetectable. And even after you're off of the hormone therapy, it stays at undetectable. But I'd say most guys, it's at a low but still detectable level. And that's just a kind of a function of how the radiation works. There's this idea that there's probably still a little bit of normal prostate tissue still making a little bit of PSA. And that's probably what's going on there. Whereas, if you see a stable but low PSA level for a long period of time, that tells us there's no active cancer growing there. It's really the key thing is the change in the PSA level over time. And we'll even see that with initial detection of prostate cancer. We have thresholds that we use for cancer detection in the PSA. But we've seen guys that have, still normal PSAs, that it's the rapid rise in the PSA, which really kind of tells us something else is going on there. But back to the question of radiation in PSA, typically it's kind of a slow process, especially when you're not on hormone therapy. It'll slowly go down. The standard messaging is it takes a year and a half or so to get down to the lowest level. I've seen it take, 2 years, 2.5 years even to finally land at this pretty low level. And then ultimately it stays down there. And then we have these metrics that we use to say, if it starts to rise and it keeps rising at a certain cutoff level, and then we say, we probably better take a closer look and see why it's increasing. But as long as it's kind of staying at that lower level, we feel good that the cancer is taken care of.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
I have a question for Dr. Matt. We recently had a guest on. Dr. Michael just mentioned hormone therapy and ADT, androgen deprivation therapy. This particular couple, if they had it to do again, they probably wouldn't do it. Dr. Matt, talk to us about ADT, hormone therapy as an option, some of the pros, the cons, when would you prescribe it, etc.
Yeah, there's so much here to unpack. We talk about the reasons guys choose one treatment versus another. The concurrent hormones with radiation is set out with guidelines based on the risk of the cancer. So this is being studied and this changes over time. But right now, the standard of care is for men with intermediate risk cancer, usually unfavorable intermediate, which is those Gleason 4+3 = 7. A lot of times guys with favorable intermediate, Gleason 3+4 = 7, we can avoid hormones. But with the 4+3 = 7, usually those guys get 6 months of androgen deprivation therapy. For high risk guys with Gleason 8, 9, and 10, the standard of care is 2 years. And in fact, some of those guys now, depending on their clinical stage, so if their cancer is palpable on an exam or what their MRI looks like, may even get additional medications to lower their testosterone further than just the standard androgen deprivation therapy. Now, when I was in training, the party line from urologists on ADT was, well, it's not chemo. You're not going to get real sick. Your hair's not going to fall out. It's just hormone treatments, and just being hormone treatments actually affects a lot of guys really powerfully. Because what you're essentially doing, and not to come up with a phrase that makes it so demonized, but you're chemically castrating them. That's what the hormones do. They lower testosterone, generally under 50, under 20, pretty darn close to 0. And all the side effects that men understand about low testosterone, fatigue, hot flashes, if they're on it for long term, we don't worry so much if guys are getting it for 6 months. But guys that are getting it for 2 years, we have to start worrying about their overall bone health. We have to start worrying about metabolic syndromes, weight gain, diabetes, either getting diabetes or diabetes flaring up.
Why would it cause diabetes?
It affects metabolism, and it certainly affects the distribution of fat to muscle. Guys can sort of lose muscle and gain more fat. So there are ways to counteract that for sure. And again, going back to our sort of multidisciplinary clinic, we incorporate physical therapy in our program for guys that are on ADT for longer than 6 months, where they have trainers, they have a gym right here in our cancer center. It's important to be active and not just walk every day, that's good, but do weights and do muscle training and do resistance training to combat the effects of ADT. It's necessary because studies have shown that guys that get the ADT for those periods of time have overall better cancer control rates at 5 and 10 years. So it's part of the process. I'll tell you though, as a urologist, it does unfortunately give urologists ways to demonize the radiation pathway. And the reason we work so closely together, Michael and I, is because we understand that right now the system's a little bit broken for guys that get diagnosed with prostate cancer. And I'm saying that as a urologist. And some of my urology colleagues may throw darts at me if they hear this, but we are the gatekeepers, right? We see the patients when they have an elevated PSA. Then we get an MRI maybe, and we're seeing them multiple times before we decide to do a biopsy. We're building that relationship. We're building that trust. Then guys get diagnosed, and the urologist, who also most of the time is the surgeon, will say, okay, you've been diagnosed with prostate cancer. You could have surgery to remove it, or you could have radiation. And with radiation comes hormones and maybe some of these bad side effects to the bowel and to the bladder. And I'll put in a referral if you'd like to talk to a radiation doctor. And not many guys are going to hear that and go, oh, yeah, sign me up. Let me talk to the radiation doctor. So we, in a sense, control that conversation a little bit too much. And it's important, we feel, for every guy to talk to both the surgeon and the radiation doctor and see which one really hits them in their heart that that's the treatment plan I want to do. So I know it's a little tangent away from the ADT, but ADT sort of becomes this way that surgeons steer guys away from radiation who would otherwise maybe be interested. But it is a necessary part of the pathway, at least for now.
Okay, well, Dr. Matt, Dr. Michael, thank you guys so much for being on the podcast. I know the listeners are going to get so informed, and it's very educational, this podcast, the episodes here today. So thank you guys so much for being on. We got friends that have sent in questions, and you guys answered them. So thank you very much for educating our listeners.
No, you're welcome.
Thank you.
Thank you. Yeah, it was a pleasure.
The study medicine in the MEVPRO clinical trials is designed to block the abnormal EZH2 activity in cells. With the study medicine's help, the abnormal EZH2 no longer promotes cell growth, and the flow of traffic returns to its normal state, and tumor growth is delayed or prevented. The goal of the MEVPRO clinical trials is to determine whether this study medicine, taken as tablets by mouth, is safe and effective. During these clinical trials, you will have regular visits to the study site, and your health and cancer will be closely monitored by medical professionals. You may experience side effects from the study medicine, such as diarrhea and fatigue. More information will be provided during the informed consent process.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, LandShay@prostatecancerrealtalk.com. That's LEL and Shay, SHAY, at prostatecancerrealtalk.com.